This Thrombo Emlyn is going to be the last lecture for the blog. I feel like I forgot the lecture or something. I don't know. Whatever, I'll still test you guys on it. It's all good. I did. So this is I don't know how to say it. It's like the bane of our existence in emergency medicine, kind of. Because as we'll find out, it's on the differential for any pulmonary or cardiac pathology, and there's a significant amount of steps and risk stratification we use for it, so it can be complicated. We'll try to get through it. There are some algorithms on here that are important to know, which always sucks trying to memorize algorithms. But before we do that, let's do some check on learning. 76-year-old female brought up by EMS from her nursing home where she's lived for the last 2 years after suffering debilitating stroke. Daughter states she's not acting like herself. Last day with mild behavioral changes, mild medical diagnosis, hypertension, CHF, hypothyroidism, vital signs 85/70, heart rate 106, respiratory 16, SpO2 93, 10.2, 2.3. So what we say, stable, unstable?
Unstable.
Yeah, unstable. Sounds like she's septic, right? She appears sick, mildly confused. On physical exam, she demonstrates bilateral withdrawals during lung auscultation. Initial EKG shows sinus tachycardia, portable chest X-ray shows bilateral infiltrates through system with pneumonia. In addition to a beta-lactam and a fluoroquinolone, what other agent is required for an aseptic ICU type player? For pneumonia, what do we think? Bank? Everybody agree? Yeah, we got to cover. We got to cover that MRSA and some of those other bugs there. None of the other ones are really antibiotics other than zithromycin, so hopefully we're not choosing the zithromycin for this. All right, good. Let's do another one. 22-year-old male brought by EMS after a single event while running during a PT test. Reports chest pain, dyspnea during running. Vital signs are stable, afebrile. Physical exam, systolic ejection, murmur, chest X-ray is normal. EKG performed, shown below. What is the best treatment for this spectating condition? What do we think about that EKG?
Some delta? Is he having like the pericarditis?
What are we thinking it is?
Probably like a viral pericarditis.
Overall, when we're looking at it, what jumps out on that EKG? So you got, those very tall R waves, S waves. So some sort of left ventricular hypertrophy. Do we see anything else on there? Might be hard to see.
ST elevations? Inverted.
Yeah, you do. You do have some inversion, yeah. What else? What do you got? Do you guys see anything in like V5 and 6 there, maybe? You look close. There's a Q wave there. So, what are we thinking? Had a syncopal event, he's young, athlete.
Oh,
Hokum,
hypertrophy.
right? Yeah, Hokum. So the EKG finding, it's not diagnostic, but it does help you when you see those findings. So it has a Q waves, and then you've got like those, large R waves. You've got some deep S waves in there. What do we do? What's our? Yes, we need to admit this patient to the hospital, but what is the outpatient treatment for this? Out of the options there.
The metoprolol?
Beta blocker, right? So much metoprolol. Yeah. What movements cause an increase in the murmur? Yeah, Valsalva. Yep, standing from squatting. Good. Good. All right, let's look at another one. EMS brings in 82-year-old female, complains dyspnea on exertion, orthopnea, pedal edema, blood pressure 132/76, heart rate 92, respiratory 22, temp 98.9, and SpO2 91 on 2-liter nasal cannula. CBC, BMP, lactate are all within normal limits. BMP is 1,080. During lung auscultation, rolls are heard based on the bedside ultrasound of the patient's IVC. What is the best initial treatment? What do we see on that IVC? Does it look good?
No.
Yeah, it looks engorged, right? We don't see it collapsing like we would expect if they were euvolemic. So this, this is a sign of volume overload. So I know you guys are not studying this yet because Women's Health is tomorrow, but what did we talk about yesterday? The different categories. So heart failure with hypertension, normal tension, and then cardiogenic shock. So what are we thinking on this one?
Hypertension.
Was that?
Hypertension.
Say it again, I couldn't hear.
With hypertension.
This one is we don't consider that hypertension. Come on. That's normal tensive to me.
So we were told last year.
Yeah, in the ER you'll be surprised, and when I'm like, they're at 180, and I'm like, yeah, it's fine. It's unrelated to why they're here. So this one's going to be furosemide. So this is going to be a normal intensive heart failure patient treatment. With the blood pressure 132/76, like we run the risk of taking that blood pressure to start nitroglycerin or any sort of nitrate on this patient. So it's going to be furosemide. Diurese some of that fluid out, see if we can improve those symptoms on this patient. All right, there's our good old textbook. Talk about the same thing, epidemiology, pathophys, how we work them up, yada yada. All right, here's the warm-up case. You got a 49-year-old male. He's got some funky looking legs there with a 20-pack year smoking history, hypertension, diabetes, presents to the ED complaining of left lower leg pain, swelling, redness, times 2 days. Season eyes, fever, recent travel, chest pain, shortness of breath, vital signs, 162 over 86, 94 heart rate, temp 99.6, respiratory 24, SpO2 98%. So we're going to get our safety net. What's our differential here? I mean, yes, we're talking about VTE, but what else could it be? What's probably more? I mean, there's something probably more common than this VTE. I mean,
Heart failure.
Compartment syndrome is something we definitely worry about.
Cirrhosis.
In the setting of like an atraumatic patient, probably less likely.
Could be cirrhosis. Edema.
Yeah, so like cellulitis is a very common cause for this, probably a lot more common than a DVT, but we're talking about DVTs and PEs today, so that's definitely on there, and then we'll get into the workup imaging, and then what's that?
If they had cellulitis, would they have fever?
Maybe, probably not, but maybe. Yeah, most of my cellulitis patients don't, unless they're starting to become septic, or it's like the infection's ascending. Which just one, if it was, they might, because it'd be pretty significant by that point. But it is something on the differential. It's probably more common because the most common site for like cellulitis is going to be some sort of skin disruption, like athlete's foot or something, or fungal infection on the lower extremity, and then you'll see that like edema there as well with the cellulitis. So it is very common. But we're talking about DVTs today, so it's not cellulitis. All right. We do our same approach for everybody, ABCs. There's a little bit different management for this one because we worry about right heart dilatation, which we'll talk about why here shortly. But these patients, can present very sick with a venous thromboembolism, especially with the PE. And it is certainly, as we get into it, we'll talk about the mortality rates associated with this. But really, we have some sort of abnormal clotting in the veins, and it can occur anywhere in the body. Most commonly, we think about it with a lower extremity or DVT involving one of those lower extremity venous or veins. They get a clot in there. That clot, causes some blockage of that vessel. It causes pain, and then we have to use some sort of, anticoagulant to treat them. Like I said, most commonly in the legs, but we do see it in the upper extremities. A lot of times that's associated with some sort of iatrogenic or recent, like they have an IV in that vein, they have like a PICC line or some other cause for that. But we do see them in other areas, but just most commonly is going to be that lower extremity. And then what we worry about is when that clot disrupts and it travels through the circulation up into the pulmonary artery, and it causes a blockage, and that's what we call a pulmonary embolism. And they're going to range from like, very, like a saddle pulmonary embolus, which is very significant, to like very minor ones, which we'll get into the different ones we're worried about here. But mostly today we'll be talking about DVT and PE. PE, so they cut, one doesn't, you don't always see one with the other, but as you can see, like PE is found in as many as 40% of DVT patients, so it's pretty high. Now, is that a clinically significant PE? Maybe not, maybe not, so we don't have to search everybody for a PE who has DVT, but inversely, like 70% of PEs do have a DVT, so it is something we need to consider when we're evaluating these patients that present with, our chest pain, shortness of breath. One of the questions we need to ask is, are they having any lower extremity pain? And then we need to do a lower extremity exam and evaluate that when we're looking at these patients. All right, so here's the incidence. So second leading cause of sudden unexpected non-traumatic death. Most patients don't present with shock, but there is still a small percentage that do. If they do have a PE with shock, it's pretty high mortality rate at 45%. So it is something we're always worried about in the emergency department with anybody with chest pain or dyspnea. We want to consider PE. Now, this is where this whole lecture is about, where it gets really tricky, is how we test them, and do we need to test everybody is the ultimate question. And we'll get into that and these different algorithms we use. But some of the pathophysiology, what we like to determine is what caused the DVT or PE or venous thromboembolism. So we use provoked versus unprovoked. So provoked would be somebody who has, some sort of cause for it, like a recent surgery, trauma, immobilization, cancer. We would call that like a provoked DVT. Maybe they were on like a international plane flight, they were mobilized. And then we have unprovoked, which most of them are usually unprovoked or idiopathic. And the reason we like to categorize it this way is because it's different treatment. So longer anticoagulation if it's unprovoked, because we don't know what caused it. Maybe they have some sort of coagulopathy, like a factor V Leiden that it hasn't been diagnosed. So we want to consider all those when we're thinking about these DVT, PE patients. And then other diseases can impede the blood flow, pretty broad, like infections, cancer. Estrogen use is one we always want to consider. Pregnancy can increase their risk for PE. And then elderly, so, every year after 50 increases their risk. All right, so, the concern here is when we get that clot that travels in the pulmonary artery, the larger the clot or clot burden, like the more significant it can affect those patients. So it leads to, an increase in that pulmonary artery pressure, leading to like right vent dilatation, and it can cause myocardial damage. So you might see an elevated troponin or BNP in these patients. And it can cause some sort of like right heart failure, especially in those like massive PEs is what we like to call them when they present with that shock type picture. So those are very concerning findings, and we'll talk about how our treatment differs in those patients. But there's the mechanism. You get some sort of clot, it goes through the circulation of the pulmonary arteries, and then you get some sort of partial pulmonary artery occlusion, or it can be like a total pulmonary artery occlusion that leads to like pulseless electrical activity. It really leads to cardiac arrest. So we want to try to catch these before they present with it. And the truth is, a lot of the patients, they say it's like the second leading cause of like sudden cardiac death, like unexplained cardiac death, because a lot of the patients die at home, unfortunately, before they even make it to the hospital. All right, so what are some other risk factors? Any immobility is going to increase the risk, and in increasing order from the size of the joint. So like, your low risk joints are going to be, like your wrist, elbow, and then it increases as you move to the larger joints like shoulder, ankle, knee, and hip is the most. So like your scaphoid, probably very low risk because it's in the wrist, or some might say the hand. Some of the bigger risks, like anybody who's immobilized from the hip, hip is gonna have a significantly increased risk for somebody who's not weight bearing. If they have whole body immobility or neurologic immobility, that's gonna increase their risk. And those are patients we try to prophylax and treat before this happens. So we usually think about this when the patient's hospitalized or if they have these significant injuries where we have to immobilize them. Post-op patients are at an increased risk for it. Unfortunately, it takes a little while for that embolism or that VTE to develop. So sometimes it can be over 10 days after the surgery. But in the ER, it's something that somebody comes in with, any sort of, lower extremity pain, edema, dyspnea, chest pain in their post-op. This is something that I'm significantly concerned for in these patients, and I need to rule it out. And then, longer surgeries, open surgeries, abdominal surgeries are going to increase the risk, and there are certain cancers that have a higher risk as well, but abdominal surgery is going to be a big one. Especially cancers that are really thrombogenic, like adenocarcinomas are certainly one that we see frequently, and it can be associated with pulmonary embolism or DVT. So if they're, having some sort of, bowel surgery or small bowel surgery for an adenocarcinoma, that's going to be like some of your highest risk for venous thromboembolism. Minimal risk for like localized cancer. So localized breast that hasn't metastasized, some cervical, prostate, non-nomatives like these basals and squamous. All right. Family history really doesn't matter, not really associated with an increased risk of VTE. Gender doesn't play a role in the first time VTE, but men have a higher recurrence rate. Smoking alone doesn't increase it, but however, it can synergistically affect some of the other causes, especially with like a smoker taking OCPs or estrogen. I would be a little bit more concerned, and it would increase my suspicion that this is DVT. So that's something we need to think about. Same with obesity. We have a lot of obese patients now, unfortunately, in America. All right, so here's some other factors. So age, it increases. Every year after 50, they're gonna have a higher risk. Obesity, so that's usually a BMI over 35, which I think, technically obesity starts at 30 BMI? So this would be like, I think morbid might be 40. So this is, pretty big patient for this one. Pregnancy and postpartum increases the risk, and it increases with trimester. So, probably see the most in the later trimesters or postpartum after delivery. We need to consider it. History of a previous venous thromboembolism. So this is why our history is always important. Like if we suspect any PE or DVT, we need to ask them if they've had a prior one. And then solid cancers, like I said, those adenocarcinomas are a big one. Leukemias and other hematologic disorders can increase their risk, especially if they're taking any of those medications they use for treatment. I'm not even gonna try to pronounce it there. Asparagus, that's what we'll call it. So any of those, and then we worry about those thrombophilias. So we want to know if they have any sort of like coagulopathy, or if they have any factor V Leiden, lupus patients. That's going to increase their risk for DVT or PE. Recent surgeries, so anybody who had surgery in the last 4 weeks, we want to know what type of surgery it was to kind of assess their risk. Did it require intubation, anesthesia, any immobilization? And then anything like limb immobility, so any two contiguous joints has the highest risk, but especially larger joints like the hip is going to increase your risk. And then any bed rest for over 72 hours. All right, indwelling catheters. This is when we might see a DVT in like the upper extremity if we have a catheter in there. And that's why, when we have inpatients that require medications, sometimes we'll give them what we call like a PICC line to help alleviate some of these, which is basically it's like a peripheral IV in your arm, but it actually goes almost all the way from the vein into it terminates like right before the heart. So it's like a very long catheter they place in there. We also change out peripheral IVs in patients, so we change those out frequently to try to avoid some of these complications. long distance travel, usually it's got, they would recommend, or the data says usually it's gotta be over 6 hours. And then it depends on whether they're up and moving around during those long travel distances. Like I said earlier, smoking doesn't increase it, but it synergistically affects it. CHF, because we have that impaired systolic function, so you may not be getting the correct circulation throughout the body, which can stagnate and kind of lead to a embolism, and then stroke. What else we got? Oh, estrogen. Anybody on estrogen, so we always want to consider this, especially with OCP use. If they present with dyspnea, any chest pain, we want to consider possibly a PE or DVT in the right setting, so that's going to increase risk. And it'll make sense, hopefully, when we talk about and I'm sure you guys have heard of the Wells criteria. We also use the PERC rule, which will cover all those. And then other inflammatory conditions like IBD can increase their risk, lupus, things like that. All right. So why is it so bad? And really it's because you have a ventilation perfusion mismatch. So you're gonna block that pulmonary artery. So you're not gonna get the perfusion you need in your pulmonary system. I mean, you still get ventilation because you're blowing off CO2, but you're gonna block that oxygen uptake, so it's not getting enough blood flow, and it leads to increased pressures, and then, it can progress to right heart failure and even poor coronary artery perfusion. So it can have a lot of downstream effects if we get an embolism in that circulation there. And then here are things we want to ask for the history, especially if we're evaluating any patient for venous thromboembolism. So any prior VTE, had any surgeries recently, any mobilization, and that could be recent travel, that could be, usually if they had a recent fracture in the last 4 weeks, they should probably still have a cast or something on there, but it is something to consider when you look at the past medical history. Any history of cancer, and then are they taking any sort of hormones, like OCPs, estrogen, testosterone, and then any thrombophilia, so if they have a history like factor V Leiden. A lot, usually it requires some specialized testing, sometimes genetic testing, so a lot of those patients are counseled to tell you if they have it, hopefully. But sometimes they don't, you never know. I've had lots of HIV patients, because it's well controlled now, they don't think it's a medical concern, tell me they don't have any past medical history, so you never know, but something we need to consider. Unfortunately, PE can be asymptomatic, and then it can range all the way up to sudden death for those presenting symptoms. A lot of it, clot burn is going to be an important factor on whether it's massive, submassive, or if it's just minimal clot burden. But everybody has a different presentation with this. That's why it makes it very difficult for us to diagnose. In the ER, we don't have a tool that's 100% specific and sensitive to rule it out without doing further testing, like exposing everybody to a CT pulmonary angio. But the number one symptom they're going to have is going to be dyspnea. So, and what we mean by unexplained by auscultation. So you're listening to the lungs, you don't hear any adventitious lung sounds. You don't have focal lung sounds in one lobe like you might see with a pneumonia. And really, the lung exam is unremarkable. You don't hear any wheezing, and you don't have a better explanation. So these are patients we want to have a higher suspicion for some sort of pulmonary embolism when we're evaluating them. So if everything's normal on your exam, then you may want to consider it with the right risk factors. But once again, we can't test everybody. The second most common symptom is going to be chest pain, which are all very common complaints in the emergency department. All right, so it says 3 to 4% have syncope. Studies kind of vary. It's hard to tell, but that's probably about average. Normally, when they, a lot of them are longitudinal studies or retrospective, so it's hard to really get identify if it's a PE when they have syncope. I only bring it up because during ClinCore, it's anybody who presents with syncope, you guys are like, stroke, PE, and I'm like, stroke is most studies are less than 1% of patients with stroke have a syncopal event with it, so I'm always like, could be, but very small percentage. So not the common thing we see, maybe some dizziness that they'll relate And the reason it's difficult to identify is because a lot of it is, a lot of the data is subjective, so they're asking on questionnaires, did you have dizziness when you had your PE, when they're in the hospital? So we don't have the best studies on it, but it is something to consider in a syncope patient. So, classically, they're gonna have shortness of breath and likely some chest pain is gonna be your classic patient. It's usually pleuritic on inspiration. Hemoptysis is rare, we can see it with it, but not. And if they have it with a PE, then that's, a concerning finding, but most commonly we'll see hemoptysis like bronchitis, pneumonia, things like that. So, they can present with any derangement in their vital signs. There aren't any that are like slam dunks for PE, because everything else, like I've said before, kind of presents the same. Most commonly, I would say in my practice, probably tachycardia is what I see with PE, but that's not, the data doesn't support this. A lot of that's anecdotal. That's probably the most common derangement I see, but the most common, picture I see is like no derangement in their vital signs that we diagnose PE on them. Yeah, usually they may have a decrease like SpO2 below 94%. And then once again, the clot burden doesn't predict the vital sign changes reliably, just because, sometimes it could be a young, healthy patient, their body compensates really well to it, versus an elderly might not compensate as appropriately. It's hard to tell. And like I said, clear lungs on auscultation. So, if during your exam you can't convince yourself this probably, this might be a pneumonia, this might be some sort of, asthma or COPD exacerbation, then we want to consider a pulmonary embolism. And then you may hear that S3 because of the right ventricular dilatation or right heart failure that could be associated with this. All right. So how does a DVT present? Usually lower extremity pain, swelling, cramping. It can be very difficult, especially when you have active patients, because they'll think it's, a calf muscle strain. So this is something we always have to, a differential we always have to have in the back of our head. Is just something I think that could be a PE. Sometimes you'll see like the picture where you have discrepancy between their lower extremity or calf diameter, and you see that swelling there. But it's not a slam dunk, because there can be a lot of other causes for that. But once again, this is something we always have in the back of our head for the differential. Is this DVT or a PE? Because these can be life-threatening. Proximal DVT, so we'll talk about the different veins, and we have some pictures, and you guys will practice doing DVT ultrasounds. But we can get if the clot's up at like the common femoral vein, like in the hip, you run the risk of occluding very large portions, and we'll talk about the signs you see, like the phlegmatia, cerulean dolens, in a second. We always, learn Hohmann's sign, but it really is not reliable and doesn't have great predictive value of a DVT. If you can palpate a cord in there, then that's usually going to be a thrombophlebitis, which is less concerning for a DVT. It could be associated, but a lot of times, we don't treat those the same as a DVT or consider them a DVT. And then here's, the red flags. And really anything that's occluding an entire vessel is a red flag. And so these patients need to be managed more acutely. So if you get that swollen, painful white limb, that's usually a proximal occlusion or venous thrombosis. And that's a vascular surgery emergency, because we don't want to lose their limb. So we call vascular surgery immediately for these ones. Same with phlegmasia cerulean dolens. So it's going to have that dusky blue color. This one, both these conditions threaten limb loss. We need to call vascular surgery stat, so it's going to be emergent. And we want to consider thrombolysis or TPA on these patients. So we want to, start looking at our TPA checklist for these patients, or fibrinolytic checklist, if we're concerned for this. All right, so now we'll get into some of the scoring systems we use. So we use our Wells score most commonly. We have a Wells score for DVT, and we have a stuff working. Wells score for Let's see. I guess I'm out of range. Hold on, battery change. All right, so we have our different well scores. So the most common we use wells for DVT, wells for PE, and then we use our PERC score, which is PE rule out criteria. So the wells for DVT, we score it by points, and there's different scoring systems, which we'll look at on our algorithm slide on how we do it. The original scoring system used like a high, medium, and low score, and we kind of risk stratify them into a category. Usually we look at it like, is it DVT likely or unlikely? So really, if it's 0, then it's unlikely. If it's any point on there, then it's going to be likely, is how we score it now. But anybody with like active cancer, immobilization, paralysis, if they got localized tenderness in those veins, if the entire leg's swollen, if they're bedridden, unilateral calf swelling over 3 centimeters, so sometimes we have to measure them. Unilateral vein edema, any collateral superficial veins, and then we also score it like, is it an alternative diagnosis more likely than a DVT? So we subtract some points for there. And then once again, prior history of any DVT or PE is going to increase their risk. And then hopefully it'll make sense, which it can be complicated how we use these algorithms at the end on how we risk stratify. But the D-dimer is a useful test to exclude venous thromboembolism, and we've kind of already talked about how it works, but clots contain fibrin and it breaks it down and we can measure it in the blood. So we can, use an assay. However, sometimes it's not as reliable because it can be elevated for a lot of other conditions as well. Which is why we have to apply or use this test in the right patient population or right, the right presentation and with the right suspicion for DVT or PE is only when it's helpful. Like I said, you can get those false positives. I think we have it on here, and it increases with age as well. So here are some false positives. So elderly, it's a false positive, and we actually have a higher range we use. So we do a little bit of calculation, or we do an age-adjusted D-dimer when they're elderly. Pregnancy, so that can falsely elevate your D-dimer in the setting of pregnancy. So that is sometimes might not be helpful. If it's normal, it can still be helpful, but not when it's elevated. So sometimes we have to use a different risk stratification for those patients. And then any active malignancy, surgical procedures, liver disease will cause it, RA, infections, trauma, pretty wide range. You can also get false negatives, so that's why sometimes it's not the best test. So if they've had, like it says, it kind of starts to normalize after 3 days, so that if they've had symptoms, for longer than that, it may not be as accurate or helpful when you're ruling them out. So it's something you want to consider when you're evaluating those patients or ordering this test. So how do we diagnose DVT? It's going to be a venous ultrasound. And, because everything's very confusing in medicine, you'll see it called a lot of different things. So we call it a compression ultrasound is a very common name for it because we're compressing the vein looking for a clot burden in there and whether it compresses. You'll see it called a duplex ultrasound, which means I'm using 2 different methods of visualization. So one, I'm looking at the vessel and I'm compressing it. So we call it duplex ultrasound. You'll see it called lower extremity venous ultrasound as well. And you'll see it probably called all those different things in test questions. Unfortunately, I don't think I have different names on mine, but I know surgery has some different names for it as well. But it does have a high, relatively high, sensitivity and specificity, especially in the right hands. And it's something you can do at the bedside. A lot of times we'll want to go comprehensive or a formal ultrasound as well to confirm it, but it's something quick, and you guys are going to learn how to do this during block 5, and we actually test you on it as well. It's relatively quick and easy once we've practiced for quite a while, so you guys will get a lot of practice with this, and it's a nice, useful bedside test. I know, if I'd have had ultrasound on some of my deployments, it would have been helpful instead of evacuating people out who had like that unilateral lower extremity edema, pain. It didn't look like a cellulitis. It would have been helpful if I, had a bedside ultrasound to say, all right, cool, we can keep this guy here versus evacuating him out. So it is a great tool to have, especially if you know how to use it. And here's what it looks like. So what we look at is the common femoral vein. So you see the artery and vein on there. On the left, that's without compression, it's normal. And on the right, you should see the vein completely collapse during your exam. So it's just a little bit of pressure we put on there once we identified the artery and vein. And then we want to make sure we see collapsibility. This is a compression ultrasound. So on the left, you have without compression. On the right, you have with compression, and you don't see anything compressed. You can also see a clot burden in there, so that one's kind of obvious. Sometimes it's not as impressive, but it can be relatively easy to spot once you learn how to use the ultrasound machine. We can also put Doppler flow on there to look at the vasculature, the flow as well. So here's another picture of our common femoral artery, common femoral vein, and you see it collapsing, so that would be a normal. And then on here, we're looking at, without compression, and then with compression, you don't see any collapse on there, and you see a thrombus, and that would be in the popliteal. So for those, we check, the common femoral vein, and then we also look at the popliteal behind the knee, are the two places we check for DVT. Let's see what we got on here. Let's see it again. Let's see it again. Let's see if we see a clot on here. Yeah, see a clot? I don't see one. You see that collapse in below there on that vessel. Let's take a look at another one. Oh, did we have another one? No. All right. So what do we do for the workup for these patients? So the same thing for every chest pain and shortness of breath or pulmonary type workup. We're getting EKG. We're evaluating the vital signs. We're going to get a chest X-ray on these patients, and then our labs are going to be tailored to ruling out those deadly differentials, like is this acute coronary syndrome? Is this like a heart failure, pneumonia? So we have a pretty broad differential for these patients. But we want to make sure we consider, pulmonary embolism, VTE in all these patients, chest X-ray. There are some board type question findings of Westermarck sign and Hampton's hump, which we have a picture of on, I think, the next slide. But chest X-ray is useful to help find those other diagnoses that aren't PE, like you may see pneumonia on there. Is it signs of volume overload or pulmonary edema? Is it pneumothorax? We use our D-dimer. We'll talk about when we use it, so it's not something we order on every patient we suspect PE, but it can be useful in the right population, and we'll talk about which ones those are. And then once again, you want to rule out all the other causes of deadly differentials for cardiac pathology. There's Hampton's hump. There's the Westermarck sign. It's like less than 5% of patients you'll see this in. But if you do, it may be helpful during your evaluation to say, yeah, I think this is a PE. EKG is not diagnostic for it. Most common abnormal EKG finding is going to be sinus tachycardia. The most common finding is probably normal sinus rhythm, or it's going to be normal sinus rhythm. But if you start to see that right vent strain, you may see some of those inversion in some of your leads. You may see incomplete bundle branch blocks. The classic finding is that S1Q3T3, which is associated with PE. However, I see S1Q3T3 all the time, and I'm not even thinking about a PE or evaluating for it. So it is something you randomly see on an EKG, without PEs, and I've seen it a lot more without PEs than with them. But it is something, if you have a suspicion for PE and you see it, it should increase your suspicion a little more for this. But there's what it looks like. You got that S wave in one, and then in 3 you have a Q wave, and then you've got that inverted T waves in lead 3. We won't get into all the EKG stuff, but sometimes inverted T wave in 3, we sometimes say 3 is free. So sometimes you'll see an inverted T wave in a normal patient as well. What do we see on here? S1, do we see S1Q3T3? Yeah, I think we see it on there, right? And then, like I said earlier, like most common abnormal find is gonna be that sinus tachycardia is what we commonly see with PE if we're getting EKG. And then this is gonna be the important part of the lecture, how we risk stratify these patients. So why don't you guys take a 10-minute break and come back, and then we'll dive into this. And I'll try not to get the most important part of the lecture. So for these patients that we suspect venous thromboembolism, we want to risk stratify these patients appropriately, which means we don't want to test everybody, and we want to, use our testing in the right patient with the right risk factors. So, unfortunately, it takes what we call clinical gestalt. So, which comes with experience, and especially when you guys are in phase 2, that's why it's important to get a lot of reps in, especially in my opinion in the ER, because I love the ER, but. In all your rotations, you can get a little bit more gestalt on what a patient might look like who has a VTE. What we don't want to do is test every patient. So we run the risk of exposing them to a significant amount of radiation, which CT pulmonary angio is like one of the higher ones. I think it's probably the highest for radiation exposure risk. Plus, we're using a lot of contrast for these studies, so we run the risk of nephropathy as well, which is why we don't want to test everybody. We want to apply it to the right patient if we're going to be ordering any of these tests. And we'll get into the algorithms here. So our first question is, what is our suspicion for PE? And we usually say, like, if it's less than 15%, that's a low suspicion for PE. And then we can start applying some of our rules based on what our level of suspicion is. So one of the rules we use is the PE rule out criteria, which is a good rule. It will reliably rule out less than 2% of the patients, which is a decent test. Nothing, especially any sort of like scoring criteria, nothing's going to be 100%, but this is what we consider an acceptable risk. So the first thing we need to do is decide whether we think they're low risk, and that would be you don't see any sort of vital sign derangement or other associated signs with this, which we'll talk about what's in the PERC criteria. So if they're low risk, then we can use the PERC criteria to guide us. And if they're low risk, the PERC criteria is negative, then we can comfortably say that we have a very low suspicion for PE in this patient, and we don't have to do any further testing. The other rules are a little more complicated, so it's unlikely versus likely, and then we decide which test we're going to order at that point. But here's our PE rule out criteria. So first, we have low probability. They have to be under 50 years old. There's no tachycardia. There's no hypoxia, no hemoptysis, no prior VTE, no recent surgeries, trauma. They're not on any estrogen or oral contraceptive. And we don't have any signs of a DVT in these patients, so there's no unilateral leg swelling. If we have a low probability and all of these are negative, then we can comfortably say that PE is unlikely and we don't need to do any further testing, which would be D-dimer versus imaging versus both, depending on which side of the algorithm we're going to look at. Other tools we like to use are our Wells criteria as well. So Wells, you separate it into low, moderate, high. Now we just say two-tiered likely versus unlikely. And then we have a DVT and a PE Wells scoring system, so we want to look at, which one we're applying in the patient. So really we say anything over 4 is going to be in the likely, and that's, that patient's going to be then tested, usually with some sort of imaging at that point if their Wells PE score is 5 or higher. It is subjective, so there is some, clinician judgment in there which can complicate things, and that's why we have to have a little bit of gestalt when we're applying these rules. So here's our Wells for PE. So they get 3 points for suspected DVT. We don't have another diagnosis. They're tachycardic, prior VTE, any surgery, mobilization, malignancy, or hemoptysis. So some of them are similar to what was on our PERC criteria. And then we want to calculate this score, and if it's over 4, it places them into the higher probability category. And then here's our algorithms. This is what important to understand on here. Let's try, hopefully we can walk through it without confusing you guys. So we start initially, do we have any sign or symptom of a PE? So that one is, can be anything, like a symptom could be dyspnea, which is most common, some sort of pleuritic chest pain. Or do I have any like tachycardia, hypoxia, any other symptom like swollen unilateral lower extremity? If we have any of those, then we need to think, do I suspect this is a PE? Like, is this likely, or is it very low risk? I think I have a better explanation. If your suspicion is low, then you can go and use the PERC rule at that point. So if the PERC's negative, then no PE. We can safely or comfortably exclude those ones. If we can't use the PERC rule, then we're going to move into our Wells scoring criteria, and we're going to look at whether it's unlikely versus likely. So is it 4 or less, or is it over 4? So if PE is unlikely, then we can order a D-dimer test. And if our D-dimer comes back in the normal range, we can safely exclude a pulmonary embolism. If the D-dimer is elevated, then we need to move over to that right side algorithm, or we're going to order imaging. And the gold standard, I think, which we'll cover in a second, is going to be our CT pulmonary angiogram. And once again, we can't have one name for everything in medicine, so you'll see it called, it'll be facility dependent on how you order. The CTPE is another common name for it, sometimes CT angiogram, or sometimes just CT of the chest. It might be another name for it. But if we're if we're moving to that stage, then we're likely going to do the CTPA. We don't, it can affect kidney function, so we do factor that into it. There's also like a VQ scan, which we don't use very often, but we'll talk about it. So for those patients that are that have a high probability, we usually just jump to a CTPA. We don't do the D-dimer test in those because our suspicion is very high. There are very few D-dimer tests I order that I don't regret, which someday it'll probably make sense to you guys, but a lot of times I'm waiting on a D-dimer and I'm like, I should have just CTPA'd him. I knew it was going to be positive. Why did I even walk down this algorithm? So that's a lot of times why we use these kind of risk stratification features. But you always have the hope in your mind, like, well, if it comes back negative, maybe they won't have a PE. But so if you're using this algorithm, and let's say you got a Wells score of 5, you're going to go right to doing a CT pulmonary angiogram in these patients. If it says you can consider low molecular weight heparin, usually we're going to scan them first. Now, if we're like almost slam dunk, we have no other explanation, may or may not start some sort of anticoagulation first, but normally we're going to image them. And on your test, you're going to image them first. All right, so CT chest angiography is going to be what we're ordering. It's going to be the gold standard, most common imaging modality, and we're looking for some sort of filling defect in those pulmonary arteries. So the contrast is going to run through there. You're going to see like a little darkened portion, and we'll show some images here. I've read thousands, no, not thousands, hundreds at least, maybe thousands, and it still can be very difficult to detect it even when you've read lots of them. So that's why it's helpful having the radiologist there to read it as well. And it can be, you have a significant amount of vasculature in those lungs that you're looking at. So that's why it can be difficult. You see so many shiny things in there, and you're scrolling slice by slice through it. My advice is, like when you're at phase 2, pull up all the images for everybody you order, which you should do anyway. You should read all your images, but some people get lazy, especially when you're busy in a clinic. But especially in the ER, we have viewers up. We don't have to log in. We have big screens, so all ERs have them. And I recommend you guys go in there, look at all the images, ask whoever your attending or staff is, like, hey, is there any like interesting images on here? And they'll usually teach and show you. So it's good to get a lot of reps in for it. One of the issues with a CT with contrast, you run the risk of developing a mild contrast nephropathy. We won't get into the data on it. It may or may not be a thing, is all I gotta say. But all right, so here's what our CT angio looks like. So we scroll through those arteries, and you can kind of see all the different little specks on there. So those are arteries you're following along the way, and you're tracing all of them. That's why it can be difficult to spot these. And if you can see like those positive arrow signs where you have bright contrast kind of surrounding, and then that less echoic area there that you're seeing. So that would be a sign of some sort of thrombus in there, or filling defect in the pulmonary artery, and that would be positive for consistent with the pulmonary embolism. Here's a large thrombus in there, so you see everything lit up. That's the contrast moving through there. And then you have those areas where it's darker, hypoechoic, and you're not getting as much uptake, and that would be a sign for an embolism or thrombus. And then here's another one which is larger. So this would be like what we may call like a saddle embolism that crosses over to both sides. And then we have our ventilation perfusion scan, not as commonly used. It can be an algorithm, like in maybe certain facilities may have an algorithm for pregnant patients. Still, CTPA is going to be a better choice. We just have to look at what trimester they're in. And we have lower dose CT scans we can use during pregnancy. So a lot of times, it's still something that can be used, but normally the algorithm, we still CTPA even pregnant patients that we have a concern for it in. But this one requires, you gotta breathe through a nebulizer and an aerosol, and then it runs an isotope through your lungs, and it looks for any sort of defect or perfusion defect in there. It is, it has a high sensitivity, especially during the perfusion portion. We're not concerned about the ventilation portion in it, so we don't really consider that. You guys don't know how to read any of these, but that's what you would see with a filling defect on there. I don't even remember last time I ordered a VQ scan. I don't even know if I ever have, actually, now that I think about it. All right, but it is still something out there. So here's gonna be our diagnostic approach. So we got one physiologic manifestation of PE, something that heightens our suspicion or gestalt. I think this is PE, so it could be chest pain, dyspnea, they could have tachycardia, hypoxia. And then we need to consider, do we have something else do we have a higher differential on our list that this could be, and we think PE is unlikely. If we do, then we need to treat that first. So if, they're gonna probably be tachycardic, tachypneic, and hypoxic if they have an asthma exacerbation. So we need to treat that first before we say, okay, this is going to be a pulmonary embolism. So, and we're moving through the algorithm here. So first one, do I think that this could be a PE? Any of those manifestations, and then you wanna look at, do I have a low suspicion is the next step. So if you have a low suspicion, then you can apply that PERC rule. And if the PERC rule is negative, then we can say no further testing. We don't need to order a D-dimer. If any of those are positive, then we're gonna order a D-dimer. Is this not working again? You know what I mean? All right, then order a D-dimer. If we can't use the PERC rule, then we're gonna look at diagnostic testing. So we'll get a D-dimer at that point. I can't PERC them out. They have some sort of positive criteria per the PERC rule. And we look at D-dimer testing in those patients. And then if it's negative, we can safely rule out pulmonary embolism or DVT. And then if they have a positive D-dimer, then we're gonna get CT angiography of the chest. We also want to look for a lower extremity DVT as well in these patients. So a lot of times we'll order that venous ultrasound of the lower extremity. Something that differs during pregnancy, since we don't want to scan all those patients with a CT scan. A lot of times when they present with PE symptoms, we'll do bilateral DVT ultrasounds on them. If we find a DVT, then we can assume that they likely have a PE, and we're going to treat, as long as they're stable, we're going to treat them with anticoagulation, the same as everybody, and not expose them to any more radiation. So one of the tricky categories here, all right, I think they have a DVT. They have an elevated D-dimer, I ordered ultrasounds, and the ultrasounds are negative, but they've got an elevated D-dimer. So this falls into a tricky category. We can't safely exclude DVT in these patients. it's, you know, it's not a slam dunk to say they have a DVT, so what we wanna do for these, we wanna repeat that venous ultrasound in like the next week, so usually 2 to 7 days. We tell those patients they need to follow up for a repeat ultrasound to ensure that there's no clot burden in those veins. And then at that point, we can safely exclude it. So this one is the positive D-dimer, negative ultrasound. We need to have them follow up the next 2 to 7 days to get a repeat. And then if we have a positive ultrasound, you know, we also want to consider PE in these patients and ensure they don't have any symptoms or signs consistent with PE. And then we treat most of these patients with the DOAC if they can tolerate it. So, and you know, the ones that can't are going to be, you know, they have a low GFR, the kid, you know, some sort of nephropathy, kidney failure, end-stage chronic kidney disease. We may have to use different medication, but most commonly we use rivaroxaban or apixaban, also called Eliquis. It's very great medication that you can manage outpatient with. If they have like a post-phlebitic syndrome, we don't really do anything for those patients other than make sure they don't have a DVT. So here's our DVT testing algorithm for DVT. So the first one was PE. This one, you know, we determine our pretest probability again if it's low, so basically 0 points. Then we run a D-dimer test. If it's negative, if the D-dimer is negative, DVT ruled out. If the D-dimer is positive, then we get an ultrasound. And then if it's negative, we rule it out. If it's positive, then we treat DVT. If we have a high probability, we go right to ultrasound. We don't order the D-dimer because we have a higher likelihood that's going to be a DVT. So we'll ultrasound if it's positive, treat the DVT. If it's negative, we'll get the D-dimer. Usually we get a D-dimer first in triage anyway, so this is the technical algorithm and how it should be applied and you're tested on. Unfortunately, in the emergency department, we like to have high productivity, or we don't, but the administrators make us. So we'll get a lot of those tests at triage before you even see the patient. So most of them will have a D-dimer first, but for the algorithm, ultrasound, then check a D-dimer. All right, here's our anticoagulant. So the DOACs are, you know, great medications. And why we like to use them is we don't require a bridge. They can take them orally, like versus Lovenox or low molecular weight heparin. We have to do daily injection. So some of the other medications require a heparin bridge to therapy, so they have to be inpatient and receive, you know, IV heparin prior to giving them the other medications, which is why we prefer these two. And they, depending on where you're at, like in military, Eliquis is the most common one we use. It's a little bit more expensive, so in the civilian world, some insurances won't cover it, and you might use rivaroxaban. They're both equivalent. Like recent studies may show a little bit more benefit with Eliquis, or that's what it did show, but I'm also biased because I like Eliquis better than rivaroxaban. If they're like pregnant or they can't tolerate any DOAC, then we can look at using low molecular weight heparin or Lovenox. Unfortunately, they just have to take a daily injection, so it's something we definitely use during pregnancy for these patients. And then there's also still warfarin out there. I've never used warfarin for a DVT. We have a lot better options now, or a PE. However, sometimes you'll still see patients on warfarin usually for valve replacements, things like that. All right. So how long we treat them for? It depends on whether it's provoked versus unprovoked. So most, you know, all of them will receive at least 3 months of therapy, and they'll need to follow up with their, you know, primary care physician. But if it's unprovoked, it might require 6 to 12 months, but that's usually up to the PCM. And then if they have, you know, persistent risk factors like factor V Leiden, they have recurrent DVTs, or some other coagulopathy or risk factor, they might require lifetime anticoagulation. And as long as these patients are stable, well a period, most of them are going to be discharged home with outpatient anticoagulation. The biggest barrier to that is going to be, you know, patients who don't have health insurance, they don't have a primary care manager or follow-up. Those are patients we always want to consider maybe admitting or establishing that care for them before we discharge them home. If it's upper extremity DVT, we treat the same as lower extremity. You know, a lot of them are associated with indwelling catheters, so we want to remove those. If they have any of those occlusion type presentation, where you got that phlegmasia, cerulean dolans, we need to immediately or emergently consult vascular surgery for those. And we want to look at, our fibrinolytic checklist and see if we need to do that before they receive treatment, or depending on how long vascular surgery can take to get there. A superficial thrombophlebitis, we don't do anything for that, other than like some anti-inflammatories. Compression stockings don't aid this condition, but it doesn't hurt to give it to them because it makes them feel like you're doing something more than Motrin. All right, pulmonary embolism. So we can treat these outpatient as well as long as they're stable. So sometimes, if they don't have any of those signs of like a larger massive PE, they're not hypotensive, they're not tachycardic, or you improve their tachycardia, maybe with some fluids when they were in there, their vital signs are stable now. They don't have any high-risk features like other things like elevated troponins or other causes like this heart failure or elevated BNP on top of it. And we can usually send those patients home on some sort of oral anticoagulant like Eliquis or rivaroxaban. And then here's our medications. You don't need no dose or anything. Just understand if they're being admitted, we do a heparin bridge for all those patients. If we're considering discharge, then likely it's going to be a DOAC versus low molecular weight heparin, depending on their comorbidities or if they're pregnant. The other medications on there require a bridge, or we don't use them very often. So we don't, you don't really, you need to know they're an anticoagulant, but you don't really need to know those ones. And then here's the most common ones, really easy to take. We start them on a higher dose initially, and then after a week for Eliquis, we decrease that dose in half. And then we do a similar thing except for 3 weeks for rivaroxaban, which is another reason I don't like it. It's kind of a longer bridge, or to get those levels appropriately elevated in the system. And then we have TPA, or thrombolytic therapy, which is for the massive PEs, which we'll talk about in a sec. So we classify PE into massive, submassive, or like less severe PE. Massive PE, so they have hypotension, is going to be our biggest differentiator for those ones. So you got a hypotensive patient, and a PE, we call it a massive PE, irregardless of the clot burden that we see on there. And these are usually signs of like heart, that right heart failure or right heart strain, so we'll have a dilated hypokinetic right vent. And that's something we can see on our point-of-care ultrasound at the bedside. Submassive would be patients with normal or near normal BP, but they have tachycardia, they might be tachypneic, hypoxic, so other causes of cardiopulmonary stress. And all the low-risk patients are receiving fibrinolytics. Really, the only ones we're considering are the massive PE patients, or if it, sometimes submassive, but you guys don't need to deal with the intricacies of that. So anybody with a massive PE does benefit from fibrinolysis or thrombolytics. So we're going to give them TPA, and there's some other findings you may see on there. They do have a higher bleeding risk. We need to look at obviously our fibrinolytic checklist and contraindications, which I think you guys are tested on your first EMED test. We'll have you again on your second EMED test. But anybody without contraindications that present with cardiac arrest, sorry, can't talk. They're hypotensive, you got signs of respiratory failure, severe hypoxemia, right heart strain on echo, elevated trope. These are patients that are going to be a candidate, or we're going to consider massive PE, and they're going to get fibrinolysis. Oh man, I'm dying. And then here's our major contraindications. So any intracranial disease, any sort of malignancy, intracranial malignancy, uncontrolled hypertension or presentation, any major surgery in the past 3 weeks, metastatic cancer. If they have any head trauma, we need to do a CT scan first for these patients. And in this setting, I think this thing like stops working. So in this setting, if they, let's say you get a patient with a PE or massive PE, you want to give thrombolytics, they had a syncopal episode or they hit their head, and we see some sort of, small or subacute brain bleed, this would be a patient that we need to refer for surgical embolectomy at that point, so that patient wouldn't get fibrinolysis. So it's important to understand that. That's one of the contraindications. You have CT findings, then we need to call the cardiothoracic surgeon for an embolectomy. We could also do catheter-directed thrombolysis. It's not up to us. This is, we still just call the surgeon, or interventional radiology, and they can perform those procedures on them. Usually if they have, like contraindications, like they have intracranial hemorrhage, if they're elderly, it might be a good option for catheter directed, just because it's a lower dose of that thrombolytic, so less bleeding risk. All right, so what's our dispositions? I kind of said it already. Anybody that's stable, we can likely send home. Anybody with massive PE or submassive, we're going to admit to the hospital. They may or may not get thrombolytics. If it's severe or massive, they will. And they usually go to the ICU or straight to surgery, so we can treat them for that. And we prefer in our low risk patients to treat them as an outpatient and send them home. I kind of already talked about special populations, so our pregnancy patients. I don't think it's very controversial anymore, but it had been for a long time. We don't want to expose them to the radiation. We have better CT scanners out with less radiation now, and depending on how far along they are in their pregnancy, it may not be really any risk at all. We don't really use MRI for these. It could be a test, but it's not as high. We don't have great protocols for it right now. But if we, like I said earlier, we suspect PE, we don't want to see. If we don't want to CT them, then we'll get bilateral lower extremity ultrasounds. If they're positive, we'll treat them. If they're negative and we still have a suspicion for PE, we just counsel the patient on the risk for CT pulmonary angio, and we if they are comfortable with the risks and benefits versus the alternatives, then we'll order it. All right, that concludes block 2. What questions y'all got? You guys want to do a test review?
Yes, please.
Yeah. All right, still got 30 minutes. Let's do it. Let's see what we got. So, big things. A lot of those check-on learnings are very similar to how the questions are going to be asked. Yeah. Some of them may or may not be the exact question, but whatever, I test some of them out. All right, well, let's start with acute coronary syndrome, myocardial infarction. I'm not trying to insult anybody's intelligence. Some of it's pretty simple, and some of the other questions are pretty easy. So somebody presents with, acute chest pain, we're suspected MI. What's our initial treatment strategy? To start with the basics. So, we're gonna get IV. Yeah, we get IV access. We need an EKG within what time frame? 10 minutes. Yeah, EKG within 10 minutes. And then, what other medication do we give them immediately? Aspirin, right? Good. All right. And then, what is the definitive treatment for STEMI? Yeah, PCI, and what's the time frame on it? Yeah, 90 minutes, and then 120 if it's a non-PCI facility. Let's say I get an EKG with an inferior STEMI on it. What's something I want to consider? What other tests would I want to consider doing? Yeah, right-sided, right? So you can get a right-sided EKG or V4R are going to be ones we want to think about. Good. I would know those 3 common medications we use for STEMI. So it was, if you guys remember, it was, and why we use, what their like pathophysiology is we have an antiplatelet agent. We want to help. We want to use an anticoagulant to help break up that clot, and then we want to use like nitroglycerin to limit the infarct size. So you guys need to know why we use those. Know your hearts. I'm not going to ask you to calculate a heart score, but I'm going to ask you to interpret a heart score. So knowing what is a low versus moderate versus high and what our treatment options are. So low, we're likely going to discharge them with outpatient follow-up. If it's high, we need to admit them for risk stratification, like stress testing, echocardiogram, things like that. What else we got here? Let's talk about dissections. So, hopefully everybody understands the presentation for an aortic dissection, acute tearing, ripping chest pain. What's going to be our most reliable test for diagnosing aortic dissection? CT angio. Yep, good. All right, and then what's our initial treatment for aortic dissection?
Surgery?
You want to control the rate of vasodilated. So when you use
Yeah.
EMED Block or esmolol is
Blood
probably the
pressure.
most common one we use because it's fast on and off. We can also use labetalol as well. Good. All right. And then what are some, what are some risk factors for aortic dissection?
Death, hypertension.
Yeah, well, the most common is hypertension. What else? Like, you could have, tissue, some sort of connective tissue disorder. Marfan, Ehlers-Danlos, good. Let's talk about heart failure. We already kind of talked about it. You will have some images on the test to interpret. So there are, chest X-rays. You're going to see some of those. I'm going to have some ultrasounds on there, so make sure you can identify some of those findings, like we saw today for that heart failure practice case. We'll have some images like that. I would know how to diagnose like a pneumothorax based on your ultrasound findings. And then some of these are pretty simple, which I know you guys don't trust anybody saying that. So, and we already talked about, obviously, HOCM, what sort of physical exam findings we see with the DPG findings. How do we, what's our, how do we definitively diagnose it? What tests do we need for?
Echo?
Yeah, echocardiogram is what we're going to be using for that. Good. You got a patient with, that pleuritic chest pain, worse when they lay down. They're stable. What's your treatment for those?
Ultrasound?
Colchicine.
Yeah, NSAID initially, and then colchicine. What does colchicine sometimes help with a pericarditis? Yeah. What's that? Well, it can help prevent recurrence in it. Is a lot of, one of the reasons we use that. What do we do for tamponade? Yeah, stick a very long needle in there. Good. That one's pretty easy. And, we just talked about PE, but gold standard test for it. Yeah, CTPA, good. And then know those algorithms and whether we think their well score is likely, so it's high, it's over 5, and what our testing is going to be after that. So it's important to know those and which algorithm we're kind of running down for these patients. I would know some of the risk factors for, venous thromboembolism, which one increases your risk factors the most. It's important to understand those. Let's see what else we got on here. Let's talk about pneumonia. So remember, how we had those different categories, whether they're outpatient versus inpatient, whether they have comorbidities or no comorbidities. So let's say young, healthy, outpatient, what are we going to treat them with? You could use a Z-Pack with amoxicillin. Yeah, usually amoxicillin and a Z-Pack for outpatient treatments, a very standard practice we use. What if they have comorbidities?
For the doxy?
Pretty much the same thing, but amoxicillin adds like augmentin. So with the clavulinase, so moxicillin and clavulinase augmentin. So a lot of times we do augmentin and Z-Pak, or we can use doxycycline as well. It's a very great drug, love it for everything. Probably take it once a year, just get rid of anything you're worried about. What are we doing for our septic patients? Like, how does our treatment differ?
Admit?
Yeah, we need to use through those
IV.
3 different categories. So some sort of, like beta-lactam, we need to use some sort of anti-pseudomonal agent, and then a MRSA agent like vancomycin is what's going to change our treatment. It's important to know those different types of pneumonia that have, for any test. Anything that has like random findings that aren't normal with it, it's important to know those and be able to identify it. So some of those other atypical pneumonias and what physical exam findings you see with this. What about, pneumonia findings, and they recently traveled and they got, GI symptoms? What are we thinking on that one? Like Legionella, right? Did they still teach Legionnaires? Do you guys know that's what it's called? Yeah, okay. Wasn't sure if that was still a thing. Good. What else we got? I already told you guys some of it during class you need to know. You guys are comfortable with the heart failure algorithm, so hypertensive, and heart failure, you're gonna, what medications are we gonna use for that one?
Diuretic.
What was that?
A diuretic, nitro.
Yeah, we're gonna look at, nitrate and then a diuretic with those. Good. And then normotensive, we're gonna look at using just our diuretic on those. And then if it's, if they're septic or they're hypotensive, sorry, not septic, they're hypotensive, then we need to look at possibly some fluids and then some sort of vasopressor on that to help improve their cardiac output. Oh, well, yes, I mean, hopefully you guys understand pneumothorax. So, if they present, you've got chest X-ray shows pneumothorax, they're not manifesting any signs of like tension physiology, so, they're not hypotensive, they're not tachycardic. What's gonna be our initial treatment for that patient? It's large, it's not small. It's gonna be tube thoracostomy, right? Yeah, so, and what about if it's tension pneumothorax? What is our initial treatment? Needle chest decompression, followed by tube thoracostomy for definitive treatment. So it's important to, recognize both those. Let's see. I don't think I have anything else unless you guys have questions. Oh, let's talk about asthma. I don't know a little bit of asthma. I forgot that one. Where did it go? Hold on. All right, so asthma, what is my initial treatment for asthma? So they come in, asthma exacerbation, what are the 4 things I'm doing?
Saba, you're gonna
Oxygen,
pump
albuterol,
oxygen,
ipratropium, or an anticholinergic, and steroids, right?
Steroids.
Good. Okay. So hopefully everybody has that. And we kind of talked about it earlier, what are we discharging those patients home with?
Steroids.
Yeah, steroids, make sure they have inhalers, and good follow-up. COPD, what are some treatment differences for COPD versus asthma? What are some of the different medications we may or may not use with those?
We're not using the Saba anymore.
Use a lot of
We're gonna use it's gonna be albuterol, ipratropium, same, oxygen, steroids. What else do we add to those ones?
There's a llama, right?
maybe.
They've got like increased sputum production, they've got a change in color. So we add antibiotics to our COPD patients. Some other differentiators, like we don't use, we could use magnesium COPD, but it's not a standard of care using magnesium for COPD. But for asthma and that status asthmaticus, we want to add that magnesium on there. It's very important.
Hmm.
Yeah, I would be able to, recognize what, like respiratory failure looks like on a, blood gas. I know you guys are like, why?
Mhm.
So, like big things, are they acidotic? So, looking at our pH initially, are they acidotic? Then we want to look at their oxygen. So, is it normal, within the normal range, or is it low? And then we also want to assess that CO2. So we're looking at like a respiratory acidosis, and if we see that like no improvement with the patient, they're acidotic. It looks like respiratory acidosis. They're they have hypoxemia. That's somebody we may want to look at intubating or a little further management on those, or more invasive management, I should say. Good. All right. What questions y'all got? I'm sure you'll have questions after Women's Health tomorrow. But you guys feel good about Women's Health? No? I don't blame you, man. It's actually the lowest scoring category on the pants. On the pants.
Oh.
Like,
Oh.
okay.
Oh my